Tonight's speakers include Stacy Griffith and Dr. Kevin Kopko, who will be giving us an overview of knee and hip arthritis, at-home exercises for hip and knee pain, the latest advances in joint replacement surgery, and answers to the most common joint replacement questions. Without further ado, I would love to introduce you all to Stacy Griffith, who is the coordinator of Total Joint Program for SOS Orthopedic and Sports Therapy. Stacy is a graduate of both Damon College and SUNY Potsdam and has advanced certification in McKenzie Mechanical Diagnosis and Therapy of the Spine. And without further ado, I'm going to turn over the virtual stage to you, Stacy.
Thank you very much. Let me get the share screen set up here. Good evening, everyone. Thanks for coming in. Again, my name is Stacy. I'm a physical therapist of 25 years, and I'm currently working at the Oswego Road office as a site supervisor. Wanted to take a few minutes tonight to talk about exercises for the hip and the knee and kind of explain the role of physical therapy and how we help with those situations and give you some guidelines about what to do at home or at your gym at the YMCA or another gym that you're working at. So briefly, just to summarize what I'm going to do tonight is talk about what arthritis does, how it impacts the knee and the hip, how PT can help guide you along the process of exercising, some do's and don'ts about exercises. There's a lot of options out there for you, a lot of sources to go through, and we'll talk a little bit about what maybe the right thing to do is and versus the wrong thing. And then if you're kind of at the end of the road with your arthritis and you've kind of exhausted conservative care, then joint replacement is an option for you, and kind of explain to you what physical therapy role is in that. We had a lot of questions beforehand about that as far as how therapy helps prepare you before and after a joint replacement surgery. And then I'll turn it over to Dr. Kopko. The basics of arthritis. Dr. Kopko will go into much greater detail about this for you in his presentation, but basically it's a loss of cartilage between the joint surfaces of the ends of the bone that causes inflammation and pain. And when that starts to develop, people will compensate and stop moving their hip and knee like they normally should and keep it more in comfortable positions to avoid painful movements. And over time, what happens that we see is that results in joint stiffness and loss of motion, and then eventually weakness. And so in physical therapy, we evaluate that and provide treatments to help improve your motion, improve your strength, and decrease your overall pain. There are a lot of sources of exercises out there. Dr. Google is a big one, the internet, of course. And just to give you an example, in preparing for this presentation, I searched the best knee exercises for arthritis. And as you can see there, I had 11,500,000 hits for best knee exercises. I also received about that many for the worst knee exercises for arthritis, and many of the exercises were the same. So my point is, be careful what you're looking at out there. Be careful looking for lists or the best exercises to do, because a lot of times they're not. You also can reference books and magazines. I don't know if people remember those. I think people our generation remembers what magazines are. They're those paper things with the pictures in them. Now we're all looking at computers and iPads and stuff, but there are magazines and books out there that are resources too. And then the TV infomercials. If you can see that picture that I put up there, that's Mr. Tony Little, who made a lot of money with that machine there called the Air Glide machine. And neighbors and friends will also recommend exercises for you to use and do and programs. And I think there are just a lot of sources out there that you've got to be careful looking at. I think the best source of exercise and advice is your physician and your physical therapist. I think we kind of look at it, instead of looking at the top 10 best exercises to do, we really kind of look at the right exercises for you to do based on what we see with your knee or your hip. We all know that exercise is important for various reasons. In regards to arthritis of your knee and your hip, Why we exercise really is to improve the range of motion, the flexibility, and the strength of your hip and knee. As arthritis develops and you start to compensate and you have restrictions and loss of motion, whether it be not being able to straighten your knee all the way or not be able to bend down and tie your shoes, that tightness and that restriction really causes a lot more friction in that joint and really accentuates the loss of the cartilage. So the exercises that we do for flexibility and strength really are aimed to decrease that friction of the joint, decrease the compressive forces, and then we would move into more stability and strengthening exercises so that it's easier for you to walk up and down the stairs, to get out of the car, to get out of that booth at the restaurant. And the pain decreases as well, which allows you to do more with less pain. So how we exercise is very important. And I think what I talked about tonight is more of what not to do for exercises and what to do for exercises. And then I'll touch a little bit more on what is a good pain and a bad pain. We get a lot of questions about that as far as, I didn't do the exercises, kind of hurt a little bit. Were they okay to do, or was I causing more damage? So I'll give you some guidance on that as well. I put this picture on the screen because I thought it was kind of funny that I don't know how many people are that happy when they're doing exercises. I know there's not many smiling faces in my office, so I thought that was kind of funny to put on there. We have a lot more frowning in our office doing exercises than those people there, but I thought that was kind of funny to put on there as a picture. In physical therapy, like I said earlier, we want to evaluate you, provide an individual treatment plan for you based on what we see. We'll provide you home exercises based on deficits in your motion or your strength that we found in your knee or your hip during the evaluation. We'll give you education and instruction on, when to use heat, when to use ice, how to stretch, when to progress. So we can give you a lot of guidelines with that that you may not find in other resources that you're looking at online or with magazines or friends. And our goal is always to improve your quality of life. We want to decrease the pain that you have with arthritis. We want to slow down its progression. We want to really kind of try to restore your ability to do things. And that's really the main goal of us as physical therapists, to really improve your function and your quality of life. In general, I think I wanted to list some guidelines of things that you should do, or kind of the to-do list and the do's and don'ts of exercise. And I move the screen, there we go. I think from our practice and my standpoint, I think stretching exercises are the most important to do. As arthritis progresses and you start compensating, you start to lose the ability to straighten your knee or bend your hip, that tissue in that capsule around the joint, the muscles and the tendons in that capsule start to shrink around that joint, and that causes you to have more pain, and it kind of cycles into more and more loss of motion. And one of the first things that we do is provide stretches to increase your flexibility, loosen up that capsule, loosen up the muscles, loosen up the tendons, and we do that in various positions. I have a couple of pictures on the screen here that we have of sitting or standing or even lying down. And those stretches can be active or passive. The passive stretch is the top picture where you're using, you'd use a towel or a stretch out strap to pull on your leg or your knee to give that stretch, and you would do a hold for a count that your therapist would tell you to do, and then release slowly. And then the bottom exercise is more of an active stretch where you would extend your hip back behind you to stretch the front of your hip. And again, you would hold and release that pretty slowly. So those are just two basic examples of some exercises that we might give you. The big question that we get a lot is what's good pain and what's bad pain? What should we keep doing? What's okay and what's not okay? And I kind of use this analogy and this example kind of like when we were kids and we played red light and green light. And I think that's a good way to kind of explain how to do that. So I'll take a couple of minutes and kind of explain to that so that you'll know what's a good pain and what's not a good pain, when to continue an exercise and when not to. A red light we would describe here in the clinic is if you do the exercise or the stretch and that increases your pain, and then when you're done with that stretch or that exercise, that pain remains elevated. it doesn't calm back down again. And then the more you do, the more that pain ratchets up and gets worse and stays worse. In those cases, we would tell you to stop. That would be a red light. When you do a safe stretch, it should be more, or safe exercise, it should be more of a yellow light. You should have a little bit of pain when you do that stretch, but when you let go of that stretch or that exercise, that pain should quickly decrease back down to where it started within a few seconds. Another analogy we use is the bent finger example. So if I bend my finger backwards, that hurts, but when I let go, that pain goes away within 2 or 3 seconds. That would be a yellow light. I'm not stretching like this. I'm not afraid to stretch. I want to produce some discomfort. I want to tell that tissue to loosen up and stretch. But when I let go, that discomfort should quickly subside within 2 or 3 seconds. Now you know you're in a safe zone for stretching. A red light would be I do that once or twice, that pain ratchets up, and I know that I can't do that stretch anymore because that's making it worse. We get that question quite a bit in therapy, and I just think it's a good way to explain it in simple terms. I'm a pretty simple-minded thinker. So, and a green light obviously would be the more you do the stretch or the exercise, the better it feels. And so that would be a green light. We usually tell you to hit the gas for that one and go. I think when you're doing your exercises, I think expectations are sometimes a little out of proportion. I think you should expect to see progress slowly, especially in arthritic knee or hip. It takes time to retrain that tissue, that capsule, that tendon, that muscle to loosen up and stay in that loosened position. So a lot of times each day when you do them, you might feel like you're starting over a little bit. But if you look at your progress week to week, you'll see that you are indeed making progress in your range of motion or your strength. Strengthening exercises, strength and conditioning, we recommend a lot of different exercises, but I just include a couple basic ones here tonight that I know people may have at home or they may have access to at the Y. Stationary bike is a big one. We all recommend that for range of motion, conditioning, strengthening. I know a lot of our doctors at SOS also recommend that too. It's good for both knees and hips. Elliptical machines are a little more questioning for me, in my opinion. I think they're okay for knees. I think they're better than a treadmill. I think I find some people, if they have hip arthritis or hip problems, tends to aggravate their hips a little bit more. So that one I'm not so sure about. But again, back to the red light, yellow light. If it's a red light and you do it and your symptoms are worse, then that tells you you're probably not one to do an elliptical very often or very much. Probably one of our favorite exercise environments to work out and exercise to do are water aerobics or swimming for people. And the benefits of the water are just fantastic for arthritis. We used to have a pool in a couple of our locations years ago, and we could never get arthritis patients out of the pool. They wanted to stay in there all the time because it felt so good. And they did very well in that. And the main reason was the buoyancy of the water. That picture I have on the screen there, that person in waist deep water is about 50% weight bearing on their hips and their knees. So whatever is underwater is essentially weightless. And so if you were in chest deep water, you'd have about 25% weight bearing on your joints and your legs and your spine. And so that allows you to do a lot more exercise with a lot less pain. And so it is one of the best environments to do exercises in because of that decrease in the compression and weight bearing on your joints. The second reason would be viscosity. So we all know that the harder you push against water, the more it resists you. And so strengthening exercises and conditioning can be done very easily in the water, and some exercises that you would have trouble doing on land would be a lot easier in the water because those weight bearing forces are restricted, but also the viscosity of the water is almost like adding weights. You also can get equipment and weights to use in the pool. I'm sure if you've been to the Y, you've seen them. They have foam ankle cuffs to use for resistance. They have ankle weights, they have paddles and fins, and all those are great tools to use to strengthen your legs, your knee and your hip in the water, which is a very safe environment. Other things to do at home, active range of motion exercises, laying down or standing. That's just one example of a straight leg raise. You could do bridging, you could do, some band exercises. Again, your therapist would help direct you through that and show you some appropriate ones to do for you. But those are just some examples of strength and conditioning exercises that we would recommend to do. And again, kind of that disclaimer on the bottom is that all the exercises should be a yellow or a green light. You should be no worse when you're done doing those. You shouldn't be crawling out of bed the next morning because you overdid it at the gym or in your house. That's probably exercise you shouldn't be doing. Moving on to the don'ts, the exercises to avoid, again, in general. We don't recommend people with arthritis in their hips and knees to do a lot of squats or lunges. Pictures of the squat rack there. I would not recommend doing that if you have arthritis in your knee or your hip. That really compresses the joint when you're in what we call a closed chain position, where you're weight bearing and then you're bending the joint, whether it be the knee or the hip. That compression and that movement really grinds that joint and really affects arthritis and those rough surfaces in your joint. Stairmasters and steppers would be other exercise that we would not recommend doing. I kind of ask people that like to do those, if you have pain using steps in your house, why would you jump on a stairmaster for 10 minutes and pound your knees like that? So that would be one that we'd recommend not doing as well. Step aerobics, you got to be careful with. I think half hour hour aerobics class, Zumba or step aerobics can really aggravate your knees and your hips, unless they're done in a water environment. Those are absolutely acceptable, or in a modified position where you're not using the step and just maybe modifying your movements so they're not painful for you. Running on a treadmill is definitely not recommended for knee and hip arthritis. For all you runners out there, I know it's hard not to. We would probably recommend to hop on the bike instead, which doesn't go very well. For the obvious reasons of the compression of the joint. That's a lot of compression on your knee. Running, I believe, compresses your kneecap against your femur, which is your thigh bone. I believe it's 8 to 12 times or 10 to 12 times your body weight force is compressed of your kneecap against your femur. And so if you have arthritis in there, that's just really going to aggravate it and really accelerate that arthritic process. Unless you're in water. Again, back to the water, you can get a very, very good workout cardiovascularly by putting some noodles under your arm and running in place out in the deep end of the pool, or running in place in the shallow end. And again, your aerobic instructors at the Y do a great job with that, and you could certainly ask them for help and questions on that. The other machine I have a picture in there is the knee extension machine, which seems to be the one machine that people gravitate to at the gym. I don't even have one in my office because it really causes a lot of pain when people use the weights, and that really, again, compresses that kneecap against the femur. And so over time doing that's just going to exaggerate your pain level and really inflame the arthritis underneath your knee. And I think the lowest the machines will go is 10 pounds, which doesn't sound like a lot, but it can be a force against the kneecap. And then in general, any exercise that you find is a red light, like I said earlier, if you're really sore that night or the next day, you probably should reconsider or think about what you did and maybe modify it or try something else. When you're at the end of the road, you've talked to Dr. Kopko or one of our other orthopedic doctors, and the plan is to have the joint replacement. Again, another question that we had quite a bit here before we did this presentation. What was the role of physical therapy before surgery and then after? We have a very successful program for a joint replacement, and one of the reasons is that we see people before surgery for preoperative physical therapy. And the purpose of that is really to prepare you, give you the most strength and the most range of motion that you can have in your knee or hip before surgery, so that you have a quicker and more successful outcome after surgery. It kind of carries over to after your joint replacement. So during those appointments, and usually only 1 or 2 visits, we would instruct you in the exercise to try to do them safely. That addresses any loss of motion or weakness that we saw. We would educate you on how to reduce the swelling, control it with ice and elevation at home before and after surgery. And then we would also show you how to use your walker, your cane, how to transfer, how to use stairs safely so that you can navigate in your house, get in and out of your house, get in and out of your car. And then we would we'd see you within that first week, usually after your surgery. So it really prepares you to get started quickly, so that you're done and back to normal in a short time. In conclusion, I think exercising at home should be individualized to you. I think you need to be careful of those top 10 best exercises and be careful of your source that you're going to use to get those exercises. I think if you have questions, you certainly can call physical therapists if you know them, or consult with your doctor. And if those pain persists in your knees and your hips, then certainly, ask to get referred to physical therapy for specific help and guidance. I'm going to turn over now to Dr. Kopko, who will give you a lot more detailed explanations about everything, better than I would. And thank you everyone for joining tonight. And if you have any questions, I'll be hanging out here and answer them at the end. Thank you.
Thanks so much, Stacy. What an informative presentation, and also a really great explanation of like how important physical therapy is. All right, so I am going to spotlight Dr. Kopko now, and I am also going to do a brief introduction of Dr. Kopko. Hold on one second here. All right, just getting all my windows in order. All right, so Dr. Kopko is a board-certified, fellowship-trained orthopedic surgeon with SOS specializing in joint replacement surgery. He earned his medical degree from Penn State College of Medicine and completed an orthopedic residency at Stony Brook University Hospital in Stony Brook, New York. Dr. Kopko completed a fellowship in joint orthopedic surgery. Oh, sorry, I just lost that. In joint replacement surgery at Massachusetts General Hospital, part of the Harvard Combined Orthopedic Surgery Program in Boston, Massachusetts. Dr. Kopko is skilled in primary and revision joint replacements of the hip and knee, fracture care, orthopedic trauma surgery, and non-operative management of osteoarthritis. So without further ado, I turn the virtual stage over to you, Dr. Kopko. Thank you so much. Oh, I need to unmute you, don't I? All right.
All right. So I think my screen is shared now. Stacy did a great job talking about a quarter of what I normally talk about in my presentation. So I've kind of pulled that out. We're going to talk about management of hip and knee pain, primarily arthritis. We're going to go over some of the anatomy, the pathology, non-operative treatment managements, the operative treatment recovery, and then some of the questions that we've already received at the end. So just to start off, kind of when you look at joints, the normal joint has a lining of what's called articular cartilage, which is kind of the blue line here between the two joints. It's got a joint fluid that's called synovial fluid and a capsular lining that's kind of the red line. The point of a joint is to provide friction-free motion, and the joint fluid tends to produce the nutrition for the joint. There's not a lot of blood flow to the joint, so the joint fluid acts via diffusion to provide the nutrients to the joint cells. They function for shock absorption and motion. When we start to look at the hip joint first, the hip joint's a ball and a socket joint. There's an acetabulum or a socket on the pelvic side. The femur is the thigh bone, which has a femoral head at the top of it, and the joint's really a ball and a socket joint. It moves in three directions. It flexes, it rotates, and it abducts or adducts, which is moving left to right from the body. In contrast, the knee joint really is a hinge joint, moves in one direction. There's a lot more at play in the knee joint because there's less motion in planes, but then there's more rotation and sliding. The main part of the knee joint is the femur and the tibia, the femur being, again, the thigh bone, the tibia being the bone below the knee, and then there's the patella as well. The knee joint has really three components. There's a medial component, which is on the inside, the medial joint line. There's a lateral joint line, which is on the outside, and then there's a joint between the patella and the femur, which is the patellofemoral joint. The secondary part of the knee joint that really gets talked about a lot in the orthopedic world is the meniscus. The meniscus are the two discs of cartilage that act kind of as gaskets to transition the shock of motion from the femur to the tibia. So what they do is they convert the round bottom of the femur to the flat surface of the tibia. So these kind of act to decrease the force transmission by increasing the area. And they're one of the things that we treat a lot. People hear a lot about meniscus tears, and sometimes those are surgical and sometimes they aren't. And sometimes meniscus tears are really more arthritis. And that's something you really need to talk to your physician about. When we really talk about arthritis, at the end of the day, arthritis is really wear and tear. It's age-related degenerative changes to the knee. It can be related to trauma. It isn't always. But in general, arthritis is an injury that, or something that occurs without a true injury. It's a worsening of symptoms over time. It's wear and tear, age-related changes. There's kind of two different types of arthritis, whether it's osteo or rheumatoid. Osteoarthritis is the age-related changes that everyone develops some of in their life. And then rheumatoid arthritis is an autoimmune disease where there's a chronic systemic inflammatory response to your cartilage and joint tissues. Most people have osteoarthritis. Rheumatoid arthritis is more of an autoimmune disease that's got some other issues related to it. As arthritis progresses, you can see here in this little cartoon, basically, the normal knee has a nice smooth joint surface on both sides. Progressive arthritis results in loss of cartilage, development of bone spurs, and narrowing of the joint space. And that's one of the reasons why we end up talking about surgical intervention, because where we are in medicine in 2021, and probably for the next 10 years, there's no treatment for regrowing cartilage. There's no recommendation to remove bone spurs when they develop from arthritis. The treatment really is talking about replacement when it gets to be advanced stages of arthritis. When we look at the knee on x-ray, kind of you can see the progression here across these couple x-rays. Again, femur at the top, tibia at the bottom. The patella of the kneecap you can kind of see is this round shadow here that the star is inside of. A normal knee has a nice smooth knee joint, nice preserved joint space. I always get films in my office when people are standing. A lot of the times people will be standing and you'll get this nice looking, or people will be laying down at a table at another center and they'll get this nice looking knee joint that looks perfectly normal. And then when they stand, you see that they've got this bone on bone change over here. So we've got a progression from a normal knee to a moderately arthritic knee where there's actually some bone on bone changes here on the inside, to a severely arthritic knee where there's kind of bone on bone changes, bone spurs that have formed here on the medial side and the lateral side. And there's also some on the patella for this patient. When we look at the hip, the x-rays are a lot more complicated to look at. The hip, we look at the pelvis, which is really the framing of the body where the hip joint starts. So the spine's at the top, pelvic brim on either side, and then the femur again at the bottom. So the hip joint's really a ball and a socket joint. You've got that nice curved acetabular line right here. You can kind of see mirrored on the other side with a little bit of arthritis up here where there's some joint space narrowing. The femoral head's again nice and round, meets right down at the femur. So when people say the hip, the problem is they kind of include this whole picture. The hip joint's really only this part down here. And then when people have fractures and things like that in trauma, which is a different situation, they could be talking about anything from a little fracture of the pubic ramus, which really don't require any surgery, to major fractures of the femoral neck, the acetabulum, or the intertrochanteric region, which require kind of surgery. When we look at the arthritic hip, I kind of pulled these pictures from people I saw last week. Again, on the left side of the screen, we've got a nice normal hip, nice round joint space, kind of some early to moderate arthritis over here, whiter joint lines, decreased joint space, some bone spurs that have formed, to a severely arthritic hip that's kind of no longer round, it's kind of getting squared off. Bone spurs that have formed here at the bottom, and cystic changes. Anytime we get to this advanced arthritis, really, we're going to be talking about surgical management. The vast majority of my talk can be summarized in these next two slides, because basically the AAOS and the AAHKS, the Hip and Knee Society and the Orthopedic Society, have come out with pretty strong clinical practice guidelines of what they recommend doing and what they don't recommend doing. Unfortunately for arthritis, the non-operative treatment's pretty simple. It's the things that Stacy talked about. It's physical therapy, wellness, education, weight loss, low impact activities, anti-inflammatories, and then potentially injections, which are technically an inconclusive recommendation. There's no other magic bullet for knee arthritis technically. There's been no real technical benefit shown to bracing. Even Tylenol even data on Tylenol is not able to recommend it, despite there being a Tylenol that's marketed as arthritis strength. On the other side of the coin, there's a lot of things that we know don't work. acupuncture, glucosamine, chondroitin, arthroscopic surgery, shoe wedges. The one thing that's kind of on there that is a little more gray to orthopedists in general, but is technically recommended against, are the gel shots or viscosupplementation. And we'll talk about that in a minute. As far as the Hip and Knee Society goes, there's a couple other really important things that I like to point out that are official positions of the Orthopedic Hip and Knee Surgeon Association. It is recommended not to use narcotic pain medication for arthritis. It's only for post-surgical patients or patients who can't have surgery in exceptional circumstances. The other position that I think is important to point out is the position on biologics. I would love to have a solution for regrowing cartilage, but in 2021, one does not exist. So treatment of advanced arthritis is not recommended for treatments including stem cell or PRP. All of those things are research-based. They're very expensive. There's no data behind them. And we don't really do any stem cell treatments at SOS. We do very limited indications for PRP. It is not covered by insurance. It is not generally financially achievable for the average patient. And then the final position, which we're going to talk about a little bit later, is that outpatient surgery for joint replacement, and this is the paraphrase one, is safe for the appropriate patient in the appropriate setting with the appropriate planning. So as we get into the treatment of arthritis, really, the vast majority of it starts with education. There's a great effect shown to understanding how the disease process works, what happens with arthritis, the degeneration of the cartilage, which we talked about. It's important to note, as Stacy talked about, the joint itself degenerates, but the soft tissues around it contract. So I always tell my patients, there's really nothing I tell you not to do with arthritis that you can tolerate doing, those green light and yellow light activities. It's better to have a painful mobile joint than a painless stiff one. If I'm going to replace your joint, I'm not going to be touching, or I'm going to try to be minimizing the exposure of the soft tissues, those muscles and the tendons and ligaments that are tight. If they're really tight, the way I fix things is I cut more bone, and we want to maintain as much bone as we can. So the looser your soft tissues are, the easier it's going to be for you to recover. The more you can do as far as general wellness, weight loss, and low impact exercise, the better you're going to do. And as far as Stacy's point, between the patella and the kneecap, there can be up to 8 to 10 times the body forces in running activities. The one that tends to bother people more is the weight-bearing femoral tibia issue, where you have 5 times your body weight going through the medial part of the knee when you're in stairs or getting up out of a chair. The other thing to remember is if you're talking about using a cane, you want to try to use it on the opposite side of the deformed, opposite side of the injury, and it should be on the ground at the same time the injured leg's on the ground. That widens your base of support and decreases the force going through the joint. I'm not going to really talk about PT much because I think Stacy did that. I think one of the key things, I always send a ton of my patients to the Y for the aquatic therapy, aquatic arthritis, and the weight loss classes that are done in the pool. It's a huge issue in my patient population, and I think they do a really great job with it. It's where my kids learn to swim, to be honest. One of the questions we got is heat or ice, and sorry for the corny cartoon, but I always think about this when people ask me. There's really no correct answer. It's whatever works for you. In general, the therapists are going to heat you up at the beginning to loosen you up and treat you with ice at the end. But I got patients that tell me that they use heat or they use ice, and there's no correct answer. As far as medications, the recommended treatment is anti-inflammatories, and not everybody can take those just because anti-inflammatories can affect your kidneys, your blood pressure, and your stomach. I generally try to keep people on over-the-counter medications because it's a lot easier to take, 2 to 4 tablets of Advil or ibuprofen over the counter than it is for me to give you a giant 800 milligram horse pill. Aleve or naproxen is another over-the-counter drug that's easily available. And then there's a whole host of prescription drugs, Mobic, diclofenac, and Celebrex being kind of the most common ones that we can prescribe for anti-inflammatories. It's important to note that you can take Tylenol with an anti-inflammatory. Tylenol should not affect your kidney or your blood pressures, and it's generally considered safer than anti-inflammatories for cardiac risk patients. But it doesn't give you the anti-inflammatory benefit that the anti-inflammatories do. Topical medications, Voltaren, which is diclofenac cream, came over the counter last year. It's a great option for the patients who can't take oral anti-inflammatories. There is less benefit that's been shown to the other available options. I never tell patients not to try topical medications, but it's hard to recommend any specific one. The lidoderm patches people seem to like, but they really don't do anything besides mask the pain temporarily. People do see some benefits from capsaicin, aspirin cream, or arnica cream, which is a natural anti-inflammatory. The key thing with all the natural drugs, arnica CBD oil, is to make sure you know what strength you're getting, and if you find one you like, keep buying it. But the strength really is what dictates the efficacy of those drugs. And when it's controlled, they're really not much different than over-the-counter drugs that are more regulated. Injections, again, technically a inconclusive recommendation from the Orthopedic Society. Cortisone acts as an anti-inflammatory in the knee joint. Dosing it in the knee directly seems to have lower systemic effects. It can cause some blood sugar spikes in diabetic patients, and I reduce my dose in those patients as well. It seems to help with inflammation, decreasing joint fluid production, which as you get older and more arthritis, you make less healthy joint fluid. Instead of having thicker watery or thicker oily joint fluid, you make thinner watery joint fluid. The other thing I'll point out that right now in 2021, the current recommendation is not to get a cortisone shot within 2 weeks of a COVID vaccine. So every day in my office, somebody's coming in for a cortisone shot right now and is telling us that, you know, they have their COVID vaccine scheduled in 2 days, and I have to tell them that the recommendation is that they come back in 2.5 weeks or when they're done their COVID dosing, depending on which vaccine they're getting. So it's just something to put in the back of your mind. The other medication, hyaluronic acid or viscosupplementation, that's one of the alternate options. They're colloquially known as gel shots. They are technically not recommended by the Orthopedic Society. I take a little bit of issue with the studies that decided that. They were very large studies, including patients who should have had joint replacements. I don't think these drugs delay joint replacement, but I do think that they work better in early arthritis than they do late arthritis. And so when you lump all those patients together, I think there is less of a benefit for them. I see both cortisone and gel shots being less effective in advanced arthritis and more effective in early. And technically, I think there's probably a little bit of a safety benefit in the younger patient with gel shots compared to steroids, but that's not been shown or proven. So that's mostly anecdotal. When that stuff doesn't work, when you've done therapy, weight loss, injections, you know, we really need to talk about surgical intervention. It's really something when you've tried everything else. It's a surgery for quality of life. There's no one who I think has a good life expectancy that has a bad disease problem that is not right for surgery if the risk is appropriate for them. My oldest elective joint replacement, I think, is 95 or 96. My oldest hip fracture that I did a hip replacement for was 98. He cleared to go home the day after surgery. Age is kind of a number in these regards. It's better to be 90 going on 60 than 60 going on 90. Who should you use for a joint replacement surgeon? You know, I tell everybody the biggest thing is to find a surgeon that you're comfortable with at a facility you want to be at that has a treatment team you trust. I think the biggest benefit of SOS is that we've got hundreds of cumulative years of experience among our joint replacement team with tens of thousands of surgeries. There's never a time when we let all the surgeons go out of town at the same time. We do mission trips every year, aside from 2020 for our Operation Walk, where we do joint replacements in third world countries. And even when we do that, when they do, you know, 100 surgeries in Ghana 2 years ago, for example, someone stays behind to make sure we can cover our own practice. We're not kind of a one-man shop, and we do complicated surgeries, and we do a lot of those together. I do a surgery probably once or twice a month with one of my partners, just because when we see complicated stuff, there's a lot of experience, and it just goes smoother with two people. As far as joint replacements in the US, there's about 1 million done a year. It's increasingly becoming safer and more successful. There are great patient satisfaction, improved quality of life, mobility, and increasing life expectancy 2 years after joint replacement. There's been great changes made in the medical technology and the materials and the implant design. As far as implants go, they typically are made of cobalt, chrome, and titanium are the two metals. In general, the bearing surface is going to be polyethylene, which is a plastic, on either a metal, which is the knee replacements tend to be metal on plastic. The hip replacements tend to be metal on plastic or ceramic on plastic. There used to be metal on metal hip replacements, which I'm sure some of you have seen commercials for, or we actually got a question about. Metal on metal hip replacements have largely been recalled because of issues with the wear on the bearing surface. The metal's toxic to the tissues around it and leads to tissue destruction. The most reliable joint replacement in 2021, in my opinion, is ceramic on plastic for a hip or metal on plastic for a knee. They tend to last 20 to 30 years or longer. Most of the revisions I'm doing for wear and knee replacements were done in the 90s, and some of the hip replacements I've revised were done before I was born. And if the old technology is lasting 35 or more years, I have a lot more faith in the newer technology from the 2000s when the new generation of plastics came out. Knee replacement can be done a lot of different ways. The most common way is to do it traditionally. There's a lot of work going on into robotic knee replacement. I'm certified for both the Cori and the Mako, which are the two available options in town. The Cori, or the new version of the Navio, is available at our surgery center. The Mako is available at Community General Hospital only. Computer-assisted navigation has some benefits, as does robotic surgery. But in general, the average patient really just needs a high-quality, high-volume surgeon. There are some anatomic issues that drive me to select a few patients for robotics or navigation, but I really only recommend about 5 to 10% of my practice for robotics based on anatomic issues. Some patients opt for it. I think robotic surgery is a little more invasive. We have to do some extra steps. Usually the surgical incision is a little bit bigger to get the robotic guidance into the wound. And usually we have to drill some pins into the bone as well. So there are little things that are different about robotics. There are certainly patients who benefit from it. I don't think there's a lot of detriment, but I also don't think it makes something better. I think for certain patients, it's certainly a better option, but it's not something I think everybody needs when they've got a high volume surgeon and a high volume center, because I think that's what minimizes the risk to the patient. As far as knee replacements go, the goal is to maintain as much bone as we can, and there is a partial knee replacement option as well. So when you look at the kind of cartoon here at the bottom left, this is a total knee replacement, new metal femur cap, new tibia, plastic liner in between. Patients who are candidates for partial knee replacement can have a patellofemoral replacement, which is just under the kneecap, or a unicompartmental knee replacement. Those patients represent approximately 5% of my practice. Partial knee replacements are right for the right patient, but if you've got arthritis in more than one spot, you need a total knee replacement. The benefit of partial knee replacement is, though, it's kind of like the difference between a double and a home run. A total is a really good double for the average patient. Knowing who to swing for the fences for is what makes the difference between a really great surgery and an okay surgery. The problem is some of the people who swing for the fences miss. And so you don't want to strike out and do a partial knee replacement when you've got arthritis in other parts of the knee that's going to need to be treated again later with a conversion to a total knee replacement. And so knee replacement is designed to increase your mobility, improve your quality of life, correct progressive deformities with age. Some people will get knock-kneed or bow-legged, and we can make that much straighter with knee replacement. And they can either be done with cement, which is done at the bottom, or a cementless knee replacement at the top. And there's really no significant difference to the way that the fixation is done. It's really kind of like a Pepsi and Coke argument. Some surgeons have a preference between one or the other. Hip replacement is a very similar design and implant fashion. So metal socket for the acetabulum, plastic liner is the most common bearing, metal stem that goes inside the femur, and a metal or ceramic head. The studies show that kind of the best wear properties are with ceramic on plastic. Again, in the lab, nothing really applies directly to individual patients. They used to do metal on metal hip replacements because there was less wear, but the wear particles are toxic. They also used to do more ceramic on ceramic. The problem is those tend to squeak and you can hear people coming, and they don't really like that. So the most reliable option is ceramic on plastic. One of the questions we got was about metal on metal hip resurfacing, which is another technology with a little bit more bone preservation. But again, that's a metal on metal technology. I don't recommend it. Some of my patients do it. I basically tell everybody who has a resurfacing, you're going to have a revision. And I generally tell patients who have a hip replacement, you might need a revision. So I don't think metal on metal resurfacings are going to last 20 or 30 years for the average patient. There's a lot of different ways of doing a hip replacement surgery, and that's something to discuss with your surgeon because it depends on your anatomy, your body type, the surgeon's comfort, and a lot of other variabilities when they plan your surgery. Same kind of goals from a hip replacement. As you can see, the x-ray of the implant over here. The goal is to increase your mobility, reduce your joint pain, and we can also do some leg length correction. This is not the same patient, but you tend to get shorter legs when you get hip arthritis because you wear out the joint space. So we can actually lengthen your leg a little bit with hip replacement to try to make you more out to length. It does not account for deformities in your spine or elsewhere in your body. The question about how long will a joint replacement last, it's a miles, not year question. It's a how you treat it, what you do. In a study from 2011, over 20 years, the lifetime revision risk of implants at 10 and 20 years is there. I think those numbers are a little low for current expectations. The reason being is the average patient that we put a knee replacement or hip replacement in now is dropping. My youngest hip replacement is 12 years younger than me. Those are the patients that really worry me because I'm going to follow them for my whole career. I tell all my patients, I follow you till one of us stops walking. You kind of get followed every 1 to 3 years for life because we want to know if there's a problem, and it's a lot easier to fix a problem when it's early compared to when the implant is completely worn out. The younger you are, the heavier you are, the faster the implants will wear out. And also the more activity you do. So the revision risk for the 55-year-old is generally 2 to 3 times the risk for the 65-year-old. After 65 to 70, it kind of becomes a lifetime risk of about 5%. Where we are in 2021, the biggest thing about where we are today with hip and knee replacement, it is not an inpatient surgery anymore. According to Medicare, it's officially not an inpatient only surgery. Sorry, this keeps skipping on me. So that means that the surgery can be done at an outpatient surgery center, it can be done at the hospital as an outpatient, or it can be done at the hospital as an inpatient. The biggest reason this comes into play is a lot of insurances will not authorize inpatient surgery for some patients. Even though the Orthopedic Society has put together positions that, it's safe to do, there are still patients who need inpatient surgery, and that can be a little bit of an insurance issue in the healthy patient. We found with our experience that with well-designed protocols and tools, we have a very successful outpatient joint replacement program that has kind of grown exponentially, partially due to COVID. A lot of our patients are coming out of the hospital, going to the surgery center, and it's grown a little bit faster than we expected. In January, we did 100 outpatient joint replacements at our surgery center. So, as our new surgery center is up on Taft Road, it's moved a little bit. We moved for the reason to increase the space, do more complicated surgeries. We have overnight capabilities for the joint and spine patients, but probably 75% of our patients that have joint or spine surgery are going home the same day. So what to expect after joint replacement? The most important thing is the planning. We plan a pain management routine. We start physical therapy in the surgery center in the hospital the same day usually. And about up to a third of our patients are going home the same day. Probably a total of 80% of patients go home by the next day, and anyone left is staying more than one night. The average patient who is independently ambulatory without an assisted device should be able to go home and do stairs the day after surgery. I've had patients as old as 98 clear to go home the day after surgery. It's really a how functional are you, what should you expect kind of thing. The key elements to our program, I think, are very good in the way that we design things. We do joint classes before surgery. As Stacy said, the prehab is really important, getting things right ahead of surgery, planning the pain medication, planning who's going to support you after surgery, setting up physical therapy, surgery at the right location, and then having a discharge plan. Very few of our patients at this point go to rehab. Right now, because of COVID, I'm really not doing any surgery on patients who think they need to go to rehab. I don't think it's the right thing to do right now. But even in 2019, my rehab discharge percentage was less than 5% for the elective surgery patient. Likewise, because it's now an outpatient surgery, it's very hard to get home physical therapy. Because it's an outpatient surgery, you have to be declared homebound. So to have home physical therapy, you need to have surgery at the hospital. You need to stay usually one night or more just to qualify for therapy. And if the therapist says you're not homebound, it's not something we can just order for you, unfortunately. It really depends on how you do. Surgery has risks. These are things you should discuss with your surgeon. The biggest thing I worry about is infection, stiffness, and dislocation. Those are kind of the highest risk things that lead to more surgery. But usually those risks are less than 1 to 3% combined. I'm going to skip over the therapy stuff because Stacy talked about most of it. Again, recovery from surgery is generally stairs the same day, independent mobility within a day or two of surgery. Most people, I've got patients that do outpatient joint replacement surgery without, that live alone, that have somebody driving to and from surgery, to and from therapy. Full recovery takes at least 3 months. It takes 2 years to get to 100%. So generally, most patients are kind of 75 to 90% better at 3 months. Gait changes, increasing your endurance and strength, can take up to 2 years. It depends how long you weren't walking normal before surgery. I'm going the wrong direction. Return to work, typically 3 weeks for a desk job, 3 months for construction. Really depends on you and your surgeon, the things that you do. Always things to discuss before surgery. Driving, you need to be off narcotic pain medicine, easy to hit the brake. For left-sided surgery, it's 1 to 2 weeks before the right side. I generally say, this is kind of just running away from me now. 1 to 2 weeks for the left side and 3 to 4 weeks on the right side. You can return to reasonable levels of activity after surgery. I let people kind of do everything. I tell them not to jump out of airplanes and not to run marathons. I've had people run marathons and nobody's told me they've jumped out of an airplane yet. But you know, I'm sure that some have. I've got one guy who plays hockey on a hip replacement. I don't love that one, but he tells me it's non-contact. I don't know that I believe hockey's non-contact. At this point, there are 9 million people in the US living with a hip replacement. I think we've got a really great data on how our patients do. We've got a data registry of over 20,000 data points on our joint replacement patients. We've got better outcomes than most of the country. And that's all stuff you can find on our joint replacement website. And if you're looking for some trustworthy sources, I think these are going to be sent to you later. The two that I really want to point out are the Ortho Info is the Orthopedic Surgery Association's patient information website. It's very good. A lot of my cartoons came from it. The Hip and Knee Society also has a patient information website, and our joint replacement program has some tailored information as well. Questions?
All right, thank you so much, Dr. Kopko. I'm going to go ahead and I'm actually going to invite Stacy back with us. Let's see here. I'm going to add myself here too. All right. So if anybody has any new or additional questions, please feel free to add those into the chat. I do have a few questions from folks who have sent more emails since, today, basically, that we can go ahead and get the conversation started. But first, I'd just really like to thank both of you so much for those informative presentations, both on physical therapy, joint anatomy, also the process of, getting into surgery and other kinds of treatments. I know you answered many of the questions that came through over the course of the last couple of weeks since we announced this series. So I just really wanted to thank you for that. One of the, so we have quite a few sort of like themes that emerged over some of the questions that came in. And one of them was, how do you know when it's time? Like, how do you know really like when it's time to like see a surgeon, to see an orthopedic specialist? How do you know when it's time to like really think about surgery? And what do you do if like you have multiple joints that are bad?
So in general, I think it's never too early to see a surgeon because the worst thing you're going to do is get informed. A lot of my patients come in with knee pain, depending on their age or hip pain, and we find out they've got very early arthritis, and I kind of send them to Stacy. A lot of my patients come in, they get a diagnosis. We talk about the education we talked about here. I send them to therapy for kind of a 2 or 3 visit program to kind of learn the exercises they can do themselves at home. And they learn a home exercise program to do on their own. Education is really the biggest component of the early management. We talk about anti-inflammatories and we can do injections if we need to. The biggest thing I tell people when they see me is I try to see 2 knees or 2 hips or a hip and a knee on the same side at the same visit. It gets really complicated when you're trying to look at 4 joints at once, or your right knee and your left hip. We've got to the point in orthopedics where basically surgeons have very limited scopes of practice because we're so subspecialized to be experts in kind of one thing. So I don't really do any shoulder surgery. I do some ankle trauma stuff, but we kind of would try to get you to the right person if you've got multiple issues that are involved. And for example, with the hip, a third of my hip patients have back issues. A third of the patients that see the spine surgeons have hip issues. And so, I see a lot of patients for the spine guys. They see a lot of patients for me, where we're kind of pointing people back and forth. As far as surgery goes, it's really when you can't tolerate it anymore and you have an appropriate diagnosis. So when you've tried everything else and nothing else works, then we start talking about the risks of surgery for an individual patient.
Thank you. Stacy, would you like to add anything to that?
I think what I hear the most of our patients is when they stop doing what they like to do and they become really sedentary. where they used to ski or walk or go to the Y and exercise, and now they can't anymore because their knee or their hip hurts too much. So when it really impacts your lifestyle and your quality of life, I think that's when you need to go have a conversation with your doctor and Dr. Kopko. That's the biggest thing that I hear is I used to be able to do this and now I can't anymore. And I'm sitting on the couch or the recliner because my knee or my hip hurts. So I think that's kind of the first warning flag that you probably need to get some help with that.
So like to summarize, basically, it's never too early to get information, right? Like if you're starting to begin to think that you might have an issue, it's probably a good idea to talk to somebody so that you can begin early preventive treatment, right? So things don't progress.
Right.
But then by the time that like you're no longer to enjoy life, then that's like a big signal that you really need to talk to someone pretty quickly.
Yeah.
Okay. Thank you so much for those answers. All right. A couple of questions have come in about the recovery timeline from a total knee replacement. I know you covered this a little bit in your talk, Dr. Kopko, but there were specific questions around like returning to daily activities, like showering by yourself or sort of like daily mobility, kind of like home kinds of things, or, if there is assistance for people planning their home care if they live alone and don't have other supports in their lives.
So, I think the number one thing is checking with your insurance to see what's covered and what's not covered. In general, it's harder and harder to get coverage for people to get support at home. I generally tell people that I recommend them planning their surgery around family and social support networks. For example, you want to have surgery when you can control the time of year you have surgery. I always say that the same kind of joke. My tax people do surgery in May and June. My educators do surgery in June and July. Grandparents are either, April when they get back from Florida or August at the end of the summer. People do surgery at the time of year when they get the most support, when they want to do it. In general, most people can shower within a day or so of surgery. I close all my wounds with suture under the skin. I don't use staples unless the skin's got specific issues. That lets you shower much sooner. Dressings come off much faster. There's much less drainage and a lower wound infection rate. I typically tell people I prefer you not to shower for 3 days, but your dressing's waterproof, and if you protect it, Press Seal is a great product for that. A couple of rolls of Press Seal will get you through a surgical recovery. It sticks through a shower, and as long as you're not sitting in a bathtub, it's usually going to last. People can get home therapy. Some insurance has coverage for support, but in general, I've got patients that do everything from their support system is scheduling Uber visits. Scheduling, Uber to get them to therapy twice a week. I've got other people that have family come into town for a week or so to get through a surgery. So I think it really depends on your level of function, but I've got people that are independent and drive, on the left side when it's a left-sided surgery because they don't take pain medicine after surgery. It just depends on what kind of person you are. We have some options for trying to minimize pain, and we really have some programs for, but it really depends on how you do. For every patient that I have that doesn't take pain medicine, there's somebody else that needs it for 3 weeks or has more significant issues. So it really depends on the patient.
Thank you so much, Dr. Kopko. Stacy, would you like to add anything?
I usually tell a patient, like Dr. Kopko says, that first week is usually I call the what the heck happened week, where your body kind of goes through things and it's okay to rest. It's okay to ice, elevate your leg, get some help with dressing and stuff. But you're okay to walk around. You're okay to stand and walk around your house. You have to be aware of swelling and edema, obviously, and we talked to you a lot about that. But that second week, really you see a pretty dramatic improvement where you're starting to forget the walker in your house. You're going downstairs, you're taking a shower every day. And so that level of function, especially now in the last, like Dr. Kopko said, 5 or 6 years with technology and improvements, it just really is quite amazing how quickly, from a PT standpoint, you're back doing things. Like you're not, going out and shoveling snow or building something in your backyard, but you're active, you're doing things, you're back to your normal everyday activities. You can cook a meal, you can do some dishes. Those are things that are pretty neat to see and hear people talk about, where, back in the old days when your surgery took, 2 or 3 hours, you were out for 2 or 3 weeks. Now, Dr. Kopko, what would you say the average time for surgery is?
It's usually less than 90 minutes. So it usually takes about 45 minutes to an hour to put in implants. and it takes about 30 minutes to close the wound. So it's very patient specific, but you know, in a thin hip, you can have it. I mean, you can put implants inside 30 minutes safely in a thin hip where there's not a lot of tissue to get through. Knee replacements tend to take a little bit longer because there's a little more cutting. You know, there's 6 cuts to make during a knee replacement versus kind of 1.5 on a hip replacement. So it depends on patient size. You know, a smaller patient's going to have a faster surgery because the bones are smaller. There's less to do. A bigger patient, it takes a little bit longer. But in general, you know, a surgery that lasts more than 90 minutes is unusual now, where it used to be the standard. The incisions are smaller. We're much better at soft tissue handling. We do less extensile exposures, and all those things kind of result in less pain. The one thing I'll say that I found with my own surgeries is when I started, I was very, very minimally invasive. And I've become a little bit more invasive because you can see a little bit easier. And when you're less invasive, you tend to stretch things. You tend to put a lot of retractors in, things are being pulled on even if they're not cut. And sometimes it's better to just make the incision another centimeter or an inch longer and release the stuff so it's not under tension. Because I think when we try to do minimally invasive in surgery and have the smallest scar you can have, I think sometimes patients have more pain from the swelling from things being stretched as opposed to being released.
One thing I'll add to that about rehab, we average about 4 to 6 weeks in PT for a hip or a knee replacement. So that can give people kind of an idea that this isn't, you know, that long of a process to really get back to a pretty good measure of function. But like Dr. Kopko said, a full recovery is going to be, you know, at least 3 months. But the need for skilled therapy is averaging 4 to 6 weeks. It used to be 2 or 3 months, you know, as long, you know, short as 5 years ago, just because of technology and the skill level of our physicians. It's been quite amazing to see.
Wow, that's quite incredible. To follow up with that, we've gotten several questions around why people might still be experiencing some pain, swelling, or numbness following surgery. So I was wondering if you could address that, please.
So the goal of surgery that I try to tell most patients is not to eliminate pain, it's to make it better. I think the average patient that has a knee replacement in particular has a little more residual pain than a hip replacement. I think hip replacements are just a better surgery. They're also easier to recover from. Swelling tends to take about a year to normalize. You know, as long as your scar's got pigment to it, when you rub your finger over the scar and the scar changes from the blood flow, you've got increased blood flow to the area, you tend to swell a little bit more. Some people have a better experience with joint replacement than others. It's very typical to have numbness on the lateral side of the knee after knee replacement. There's a little nerve in the skin that gets cut. There's almost always numbness associated with that. Or with an anterior approach to the hip, there's always numbness in the thigh, just because there's a skin nerve that tends to be in the area of the incision. It's usually very well tolerated, but some people do find that numbness to be aggravating.
Thank you. Stacy, would you like to add anything to that?
No, he said it all.
Okay, thank you. Let's see. There's a comment here from Barbara who says that PT helped her a lot. She'd like to get some more exercise recommendations for her new activity level and is wondering if she should visit a physical therapist or programs at the Y. So I can answer on behalf of the Y. We do have a variety of different kinds of supports, including personal trainers. We've got an arthritis group and a variety of different kinds of things that I can connect you with if you would like to email me. Again, that email is virtual@ymcacny.org, and I'm happy to connect you with things at your specific Y or at other locations. We also have a lot going on virtually. But Stacy, would you like to talk about, you know, like the possibilities of just connecting with physical therapists?
Sure. I mean, she can always call her therapist that she worked with and maybe ask some questions over the phone. We do that quite often and give some advice, recommendations. You know, if you're not having any pain and you have, you know, considerably a normal joint, then really it's up to you what kind of activities you want to try. You know, obviously start slow and work your way up to more aggressive things. But you know, in those cases where you're not having issues with your knee or your hip, just a phone call with your therapist. We certainly could help you out over the phone or give you some advice and you know, kind of help you that way. If you have pain or you have some concerns about things, then you probably should schedule an appointment for us to take a look at and make sure there's nothing that you would need to see Dr. Kopko about or one of the other physicians about with that. But yeah, we do have that happen. And if Barb's a patient of mine, I don't know what Barb's last name is, but certain call me, absolutely.
The other thing I would say is a lot of our patients go back to therapy at the 6-month mark just for kind of a tune-up. you tend to hit a plateau when you finish therapy where you're kind of tired of doing therapy, you've done all the work, you kind of do it on your own. And then a lot of patients at 6 months are like, I can't believe what I could be doing because I couldn't do it before. And so there's definitely a tail off to the plateau, and people who go back for like tweaks to their gait, how to walk better, endurance, strength, things like that, where there is a big bump of people who go back to PT between 6 months and a year at their 6-month checkup, where it's like, maybe I'll do 2 visits of PT. I can do stuff now I couldn't do. What should I do? And I think that's a great reason to go back to PT for a visit.
All right, thank you. And I'm gonna do one more question. So one of our, let's see, from Steve, he asked if he were to, determine with his surgeon today that like surgery was the option, what does that timeline kind of look like? So from someone to like walk into your doors expecting that they may need this, what's the timeline towards when they're on the table?
That's really hard to answer because of COVID. So before COVID, I usually told people it's 6 weeks to get on the schedule easily, 4 weeks to be tough. You need a medical clearance. You need to be seen by your primary care doctor. We need to get insurance authorization. There's a whole process on the back end. There are people that I can get into surgery in 2 to 4 weeks if it's an emergency. In general, hip replacement, knee replacement is not an emergency situation. So getting all the I's dotted, the T's crossed, making sure you're optimized for surgery usually takes about a month to a month and a half. I typically tell people in a normal year that I like 3 months of notice, because if you say today I want surgery in May, that's usually when we're busy. So knowing in February or March for May tends to help, because believe it or not, medicine's a seasonal business. People don't want to do joint replacements in December, January, and February in Syracuse. We don't include plowing with our joint replacements. It just depends on the time of year. But right now, the average doc in our group is usually, I think probably 6 weeks is probably the safest answer. Some docs are booked farther than others. And just the other kind of 2 questions I see there, the average joint replacement surgery technically is an overnight surgery, but that's still considered an outpatient. Anybody who stays in the hospital less than 2 nights is considered an outpatient for the purposes of surgery. And in general, I close the wound up to the skin, and the assistant closes the skin. The point at which you can't have 2 people sewing at once, I usually start dictating the operative report, call your family, let them know we're finishing up, and let the assistant do the skin closure, because I closed it for 3 years. And once I made sure that they closed it to my satisfaction, then I let them do it. And they do a very good job. The honest answer is the average orthopedic surgeon doesn't close the skin on a joint replacement. And you probably want the PA to close the skin, because they will in general make the incision look better than I will for the infrequency that I close the skin on the joint replacements now. We've trained our PAs with the plastic surgeons. We do suture under the skin instead of staples most of the time. And they look much better than they used to. And I think Stacy can attest to that probably more than anyone else, because he's actually done some studies on it.
Wonderful.
Yeah, they look amazing.
Well, thank you so much, gentlemen. Any final closing thoughts that you'd like to offer our attendees tonight?
I think the biggest thing is just it's not something to be scared of. It's better than it used to be. If you don't know somebody who's had surgery in the last 5 years, it's a different world. The people that come in that tell me that they had their father or their grandfather or someone they knew had surgery 10 and 15 years ago. I mean, I kind of joke, like, was it done when I was in elementary school, when I was in high school, when I was in college, when I was in med school, because the shift has been so rapid. I mean, I have a slide in another talk that goes over the length of stay based on my age, and it's scary.
Thank you. Any final thoughts from you, Stacy?
No, I mean, as far as joint replacements go, I'm just amazed what people can do in the short amount of time within the last 5 or 6 years. So I think it's pretty neat and pretty amazing. And if you're at that point, it's not as bad as you've heard. It usually is a pretty life-changing event.
All right. Well, thank you so much, Dr. Kopko and Stacy, and thank you to everybody who logged on tonight. We will be in touch with a follow-up email to everybody that registered for the event tonight with resources, links, and information from both Dr. Kopko and from Stacy, as well as more information about how to get in touch with us at the Y. Just to let you know, we are open. We are open right now. Our pools are open. Our fitness rooms are open. We do have virtual and in-person fitness classes, and we would love to welcome you back. We are on a reservation base, and we do have limitations on the amount of people that are able to be in the building at one time, but we are here for you, and we would love to see you all, whether it's virtually or whether it's in the building. So we will see you again. Please do register for our next event, which is coming up next week, and those details will be headed your way in an email. So good night, everybody. Thank you so much for joining us.
Thank
You're
you.
welcome. Have a good night.
Good night.